Thank you, Manu. Thank the organizer for bestowing this honor on me, on honorary lecture. I hope I'm going to justify that. The word evidence is probably the word that we hear most in recent years when we talk about medicine, and I'm going to talk about evidence-based medicine and hemodynamic monitoring. This is my disclosure. I cooperate with Pulsion and until recently cooperate with some other companies. And hemodynamic monitoring is a topic that we are all very familiar with. This is from a recent consensus of 16 in which we said that it plays an important role in the management of acutely ill patients since it may help to identify the underlying pathophysiological processes so that appropriate forms of therapy can be selected, or it can allow preemptive action to be performed before a significant problem arises. Now, most of us would agree with that, but some people are not believers in hemodynamic monitoring. Take this paper, Monitor Wizardry, the extensive use of undocumented and potentially dangerous serial measurement that might lead to disastrous changes in patient management. This is 1998. A more recent one, 2008, Gizmo idolatry, refers to the general implicit conviction that a more technological approach is intrinsically better than one that is less technological. And back to the Robin paper, Monitor Wizards frequently overlook the importance of evidence-based medicine and the requirement for evaluating therapeutic and diagnostic measures in terms of impact on patient outcome. And he is correct, because the youngest of the nurses trainee or doctor's trainee can ask us, is there evidence for what you do when you monitor? And unfortunately, the question is difficult to answer, and this is what I'm going to discuss. Now, the problem is so important that indeed it was discussed in this official multi-society statement that Professor Malbran already mentioned. It's the American College of Chest Physicians, American Thoracic Society, and Society of Critical Care Medicine. And they say that critical care medicine is a large part defined by careful monitoring, real-time analysis of many physiologic variables. But there are pressing and complex questions regarding the value of clinical research in our bedside practice. By clinical research, they mean evidence-based medicine. So we know that evidence-based medicine is conscientious, explicit, judicious use of current best evidence in making decisions about the care of individual patients. And this is the first paper in which the concept was described, and you see that EBM requires new skills of the physician, including efficient literature searching, application of formal rules of evidence that we all know. There are a grading system of evidence, and we know that the randomized controlled trial is the highest form of evidence that is expected today. And with kind of a haughty tone, this Sackett said, if you find a study that was not randomized, we would suggest that you stop reading it and go on to the next article. And Wikipedia tells us that us experts, we are the lowest form of life on this earth. And all experts are now expected to reference their pronouncement to scientific study. Can we accept that? This is from Martin Tobin. Martin Tobin was the editor of the Blue Journal, the American Journal of Respiratory and Critical Care Medicine. And he said, of course, EBM is attractive. It offers a mean of coping with uncertainty. Given physician responsibility to make life and death decision about another human, the wish for certainty is understandable, but these wishes are contrary to the reality of medicine. This is an article I find in the New Yorker in the lay press, and it is called, Is There Something Wrong with the Scientific Method? The Truth Wears Off. And I picked up a sentence out of it which really describes the relationship between evidence-based medicine and hemodynamic monitoring. And it goes like that. Just because an idea can be proved doesn't mean it's true. And just because an idea is true doesn't mean it can be proved. And I'll show you what I mean. First of all, let's see, just because an idea can be proved doesn't mean it's true. Well, this is a name that you all know, Archie Cochrane. He himself said, between measurement based on randomized controlled trial and benefit in a community, there's a gulf which has been much underestimated. Because epidemiology does not provide information necessary to treat individuals, and there are difficulties with the randomized controlled trial to which evidence-based medicine tends to give such importance. This is Ioannidis, one of the famous epidemiologists, and he said it would really be great if initial studies gave us accurate summary of things, but they don't. And so what happens is a waste of a lot of money, treating 1 million of patients, doing lots of follow-up studies on other themes based on results that are misleading. And in intensive care, it is even worse because we don't have many RCTs to support therapeutic decision. And even when we have well-conducted study, there are still many unanswered questions. This article is, I think, a must-read, okay? Now it's called Getting Off the Roller Coaster, and he said, tremendous time and resources have been expended and implemented new protocols that incorporate emerging evidence from medical literature, only to remove them a few years later when validation trials fail to confirm the initial results. And the net effect of these positive-negative cycles of frustration, exposure of patients to costly treatment that may not be of benefit but could rather cause harm. And here we have some articles that already say maybe randomized controlled trial is not the way to go. Blasphemy. Here are some examples. This is the famous Ebert study. He said we should transfuse patients only when the hemoglobin goes below 7. He also said our conclusion may be generalized to most critically ill patients. But this is further analysis of the Ebert study in which they showed that there is severe misalignment. And that is, if you have patients with ischemic heart disease, they have to be transfused in a higher hemoglobin levels, and younger patients with the low ones. And this is why transfusion decisions need to consider individual patient characteristics. And the decision to transfuse is too complex and important to be guided by a single number. The Vandenberg study in the New England Journal of Medicine, this is what people have to say about that study that changed our practice. Perhaps the most important question from a decade of studying glucose control is how influential practice guidelines were developed, yet turned out to be harmful. After 20 years, it is shameful. By now, we ought to be able to tell what constitutes reliable evidence. I think this is a very important sentence because we have all adopted evidence-based medicine as a new religion without really knowing how to produce good evidence. And at present, too many guidelines include poor quality evidence that may well be harming more patients. Guidelines rarely allow individualization of care, flexibility, managing complexity. Physician would be better off making clinical decisions based on valid primary data. All guidelines committee begin with implicit biases and values. And you think if that is not true, you're wrong. That is true, which affect the recommendation they make. And here in the Wall Street Journal, they say, why quality care is dangerous. The growing number of rigid protocols meant to guide doctors have perverse consequences. Tomorrow, I'm going to talk about the Surviving Sepsis Campaign Guidelines. This is, I think, an example of what I'm talking about. Here is a bibliometric analysis of the top-cited clinical articles related to sepsis. The first one, do you know which one it is? It's the Sigris study. And you know, following that, Sigris was implemented in the 24-hour bundle of the Surviving Sepsis Campaign Guidelines. But look what they say about this study by Gordon Bernard. The outcome of the trial outcomes were also clouded by ethical questions surrounding the sponsor hiring a public relations firm to assemble a task force consisting of many members with conflict of interest to promote sepsis treatment bundles that would include the drug despite a single positive study and lingering controversy. I call this the toxic effect of evidence-based medicine. One study changes our practice. Why? Because randomized controlled trial is the new messiah. And what is the second most cited article? It's the Rivers study. Interestingly, it appeared in the same issue as the Vandenberg study in the New England Journal of Medicine, two randomized controlled trials that change our practice. And until today, the Surviving Sepsis Campaign recommends that we bring our patient to a CVP of 8 as the first step in the resuscitation of the septic patient, which has absolutely no physiologic rationale. In fact, it was already found that attainment of CVP of more than 8 and SCVO2 and 70 did not influence survival in patients with septic shock. And all the studies that showed that there is an improvement in the surviving sepsis, following the Surviving Sepsis Campaign guidelines, it is only because of the antibiotics. And current sepsis bundles may force physicians to provide unproven or even harmful care. The toxic effect of evidence-based medicine, one study, the Rivers study, changed our practice. Here, we're talking about evidence-based medicine. This is very recent in critical care. The guidelines attempt to include nearly every aspect of critical care potentially related to sepsis, perhaps losing focus in the process. The evidence behind the bundle is not strong, and the guidelines highlight the fact that the grade system, as you know, that is grading and the evidence and the recommendation, though transparent, is still subjective. The recommendation depends greatly on the values and preferences of the committee members. This is evidence, is it? And because of that, people are made to comply. Electronic records are being sent to the central office to see who is compliant and who isn't compliant regarding the Surviving Sepsis Campaign. How can that happen? This is the secret. This is the first article on evidence-based medicine, and they say, they claim, they boast, evidence-based medicine de-emphasizes the role of pathophysiologic rationale. This is what Martin Tobin had to say about it. The developers of evidence-based medicine wrote that evidence-based medicine de-emphasizes reasoning based on pathophysiologic rationale, and this is a practice of medicine that is divorced from the scientific principles that are its foundation. I think this is especially true for intensivists and for anesthesiologists who are doing everything they do, nearly everything that we do, based on pathophysiologic rationale. This is where the rift is. Now, I talked about just because an idea can be proved doesn't mean it's true. Now, let's see the opposite. Just because an idea is true doesn't mean it can be proved. Take the speedometer, my favorite example. How were speedometers put in cars? Randomized controlled trials, 10,000 cars with, 10,000 cars without. How come they put this gizmo that measures speed in airplanes to prevent crashes? Is it based on evidence-based medicine, or is it based on technological development and improvement? And as Tobin said, the assumptions behind evidence-based medicine fly in the face of research outside medicine and ignore the revolutionary changes in the philosophy of science of the 20th century. Now, everybody knows this and probably agrees. There is no broad evidence that any form of monitoring improves outcome in the ICU, and most commonly used devices have not been evaluated by RCT. The best example? Pulse oximeter. Here is the famous randomized controlled trial. Lots and lots and lots of patients. Pulse oximeter didn't make a difference. But you know that it does. How come there is no proof for it? Here, this is in 2009. We found no evidence pulse oximetry affects the outcome anesthesia for patients. 2013, randomized controlled trial have not shown routinely monitoring patient pulse oximetry in the perioperative period deters adverse effect. But that is not true. And this is the close claim of the American Society of Anesthesiologists, showing that from the 70s to the 80s through the 90s, there is a decrease in the number of claims, malpractice claims, due to respiratory events. And this is only because of the introduction of pulse oximeters and capnography into clinical practice. The same goes with the percentage of claims deemed preventable by additional monitoring. So what we know, what we feel that these devices make a difference, here there's a proof. It's not a randomized controlled trial. This is the minimal set of monitoring put by the in Harvard and adopted by the American Society of Anesthesiologists. Every anesthetized patient should have an electrocardiography, blood pressure, heart rate, pulse oximetry. Absolutely no evidence for anything. But that's the Bible for us. Why is it? Pathophysiologic rationale. So what do we do now? Here we have a randomized controlled trial showing that measuring cardiac output makes no difference. Shouldn't we measure cardiac output? Here, another one, ICP. Don't measure ICP. I'm sure there's some people here in the audience that feel that they made the right decision based on the measurement of ICP. But you have here a randomized controlled trial telling you that ICP is no good. Now, there is a problem. When you try to validate a monitoring technique, when you try to prove that what you feel, that what you think you know, that you are sure you're doing something good for the patient, that your decisions that you make based on hemodynamic monitoring are going to improve the outcome, but you feel so frustrated because you cannot prove it. So that is one of the problems. Because monitoring in and by itself is not doing it. It's what you do with the numbers. Also, you can monitor, everything can be great, but 15 minutes of inattentive monitoring or therapy is going to destroy everything. And as Jean-Louis Vincent and others said, the application of invasive monitoring data is very complex, not easily included in therapeutic protocols that are applicable across heterogeneous population of acutely ill patients, and indeed reality may be more complex than initially thought. Those that want to do a CVP 8 to 12, one size fits all. No, reality is more complex. And this is why we have to go back to physiology. Because of this complexity, because of this uncertainty that characterizes our practice, we have to re-emphasize pathophysiologic rationale. And I end with a positive message, because this is the message that Manu already showed you at the beginning, the message of the official multi-society statement. The results of clinical research, that's evidence-based medicine, pathophysiologic reasoning, and clinical experience represent different kinds of medical knowledge that are crucial for effective clinical decision-making. Each kind of medical knowledge has various strengths and weaknesses when utilized in the care of individual patients. No single source of medical knowledge is sufficient to guide clinical decision. No kind of medical knowledge always takes precedence over the others. The pendulum indeed is swinging back from the holy evidence-based medicine. So in conclusion, hemodynamic monitoring is essential for proper decision-making, critically ill and high-risk surgical patients. The fact that this statement is not supported by evidence-based medicine tells us more about the shortcomings of evidence-based medicine than those of hemodynamic monitoring. Thank you for your attention.
Okay, thank you very much. We'll have questions at the end of this opening session.